Good morning. Dr. Linda Brecker. I'm a rheumatologist at Rowan School of Osteopathic Medicine. I'm very happy to be here today and to welcome you to our Women's Health Symposium. So we developed the symposium in order to help promote women's health and women's health issues. And we hope to do this once a month at the same time, second Wednesday at noon as a lunch and learn. And our intention is to go over health topics that pertain to women. That can be about your own personal health. It could be emotional health, physical health, mental health. And also, I think we're going to try and include family health because we know that women really are the gatekeepers for healthcare for their family. So today we have two speakers, which are very near and dear to me, two women I've known for 30 years and practiced side by side. And the first will be Dr. Joanne Kaiser-Smith, who is a professor of medicine and an associate dean at the Rowan-SOM. And she's going to be discussing adult vaccines. Are you up to date? And we know that vaccination is a big issue these days, and I'm going to let her just take that away. After that, we're going to talk about tips for the care of common sports injuries with Dr. Kathy Lambert, who is an associate professor of family medicine and also a specialist in sports medicine. So we hope this will be great content, and we're going to get going. We're going to hold questions till the end. So after both presenters are finished, then we're happy to answer any questions that you can put in the chat section of your screen. So Dr. Kaiser-Smith, take it away.
Okay, thank you, Dr. Brecker. I'm going to share my screen and you'll be seeing my slides. So my slides are not particularly fancy, but they're full of facts. And what I'd like to do is have you follow along with some of the important issues that I'm going to talk about. This could be an hour to 2 to 3 presentation, but I think if I can get you to understand some of the bare minimum, you will be much more aware. And for everyone who's in attendance, we do have a handout about adult vaccine that we're going to send to everyone should you want at the end of this session. So that's who I am, and I'm going to do there we go. So who makes recommendations to the healthcare community? Well, number one, they go 2 ways. It comes from you as the woman, as the mother in the family. You tend to be the one that has to secure family care for the parent you take care of, or for yourself, or for your children. So it's known that women are the main consumers and identifiers of healthcare, not for themselves, but also for men. At the level of science, the Advisory Committee on Immunization Panel, the ACIP, is part of the Center for Disease Control and Prevention. And they are the organization that's responsible for these recommendations. They review all the science, the literature to come up with what is correct. This is available on the website and it's updated every year, and it usually comes out in February. So we're pretty, hot topic right now. And interestingly, this committee is meeting this afternoon because of the recent J&J vaccine concerns for the COVID vaccine. So they are active. You may never have heard of them before, but they're meeting today to discuss the J&J vaccine. So what is a vaccine? It's a tool we use to prevent infection. We know that if we don't get sick, that's a great thing. We as physicians take care of you when you are sick, but we really like to have you not get diseases that you can prevent with proper vaccination. So the vaccine works with your own body's natural defenses to develop immunity, antibodies that exposed to the infection, your body will be able to fight that infection. Now, there is a safety system to make sure that they are as safe as possible, but vaccines do have side effects, as we've heard today with the active vaccine right now, but there's a wide spectrum of side effects. And very few people are truly allergic to the vaccine. You may have side effects, but that's your immune system saying to you, I'm working. So what questions? Why are you listening today? What vaccines are best for me? Why do I need specific vaccines? And I never get sick. Do I still need a vaccine? And can I get sick from the vaccine? So let me just address a couple of these right now. You're listening because you want to be educated for yourself and for your family. The vaccines best for you, I will address. I pretty much break down into age brackets. We have everyone who's 19 and above. We're not talking about children. And we usually group this into young adults that start at the age of 18, then middle age, which I guess can be considered 50, and then geriatrics, which is 65. Although a lot of these vaccines cross over those ages, those are just some very basic breakdown specifications for age. You never get sick. Do I need a vaccine? Yes, you do. You may not ever get the flu, but the one time that you do get the flu, it could be fatal. So yes, you need the vaccine. And you can't get sick from the vaccine in the sense that you don't get the disease. Again, you can have side effects, but you don't get the actual infection. I can't not talk about COVID-19, and here's my comment. I'm not going to talk about it today, other than tell you that as a healthcare provider, I strongly encourage everyone to obtain the vaccine, as indicated when it's your turn on the list. The best vaccine is the one in your arm. I didn't create that one. That came from Dr. Fauci, and the sun rises and sets on what he says, in my opinion. If you have any questions, you have to consult with your own physician or your healthcare provider, who will be able to answer your questions about the vaccine. A day does not go by that Dr. Brecker, Dr. Lambert, and I don't get some sort of a notification in our email about more things to know about COVID. So, vaccination versus immunization, what's the difference? Well, when you vaccinate someone, you are introducing the vaccine into the body to provide immunity and provide protection for a specific disease. So when you had your flu vaccine, your shingles vaccine, your COVID vaccine, you were vaccinated. Immunization is a more global term. It's the process by which a person becomes protected against the disease through vaccination. And we tend to use these titles interchangeably. So for the purposes of today, I'll probably use the word vaccinate. So here's a very long list of vaccines that are available to and should be given to certain adults. When I say adult, it's at age 19. The childhood starts at age 16. I'm sorry, at 6 months, and then goes to the age of 18. So if you are 18 and a half, you may be straddling both age brackets. It depends upon how good you are about getting your childhood vaccines. So here's a long list. We are not going to speak about all of them. But as you can see, you may be more familiar with a few on the list: influenza or shingles, HPV, and the tetanus vaccine. Others are more for specific situations. The hepatitis A and B have their own indications for vaccine, and very infrequently will you see adults getting Haemophilus influenza. So I wanted to focus on just a few. Here's age 19. Most importantly, influenza, HPV, and Tdap, which is tetanus. We'll talk about these shortly. Age 50, influenza, shingles, Tdap. As you can see, I called it influenza one time, flu the other. They're interchangeable. We just call them different things. The pneumococcal vaccine is indicated at age 50 for certain populations, but it might be at younger as well. Again, too much in the specifics. And when you turn 65, everyone needs to have a flu vaccine regardless. Pneumococcal vaccine is for all adults. And then Tdap and shingles are still present had you not gotten them earlier. So we'll go through some of these vaccines to clarify. So Tdap is tetanus, diphtheria, and pertussis. Now, as a child, you had these vaccines through multiple vaccines. It was DTP. Your parents or your grandparents or your loved ones took you there. You had both boosters in your teenage years. And as an adult, you should have a tetanus vaccine every 10 years. And the recommendation is to do it on the year when you turn 5, 45, 55, so you can remember what it is. Why is it coming back to be so prevalent right now? Because of the P part, the pertussis. Pertussis is whooping cough. And children get vaccinated against whooping cough, but they don't really get it until they're almost a year. And they're not fully vaccinated by the age of 1. So for all of those adults, those parents and grandparents and daycare workers and you know, your aunt who's coming in for a month to help you, if they have been vaccinated, which they were for this condition when they were younger, as they've gotten older, their immunity has waned. They've lost their immunity. So if they actually catch this infection from someone else, they may not get very sick with it, but they have the chance of giving it to the infant. And that's about a 90% chance that that infant will get pertussis if you have it. The way to think of it is the TV commercials with the big bad wolf. That's the pertussis vaccine. So if you are the adult exposed to children less than 12 months old, I have people come in who are going to be grandparents, and the daughter says, you're not coming to see my child until you have this vaccine. Believe me, they get it. If you're pregnant, you're able to get this vaccine. It's indicated in pregnancy. I don't like to speak about vaccines in pregnant women, but this one is a definite. And if you're a new mother and you didn't get the vaccine during pregnancy, you can get it after pregnancy, after you've delivered. So very important, focusing really on the younger population of women, because you're the gatekeeper for this, for the older population, to make sure that your children stay safe. HPV, human papillomavirus, okay? This is a virus that spreads through sexual contact. When this virus attacks, you won't know it because there are no symptoms. When this vaccine came out, it was not received well at all. It was felt that by giving a vaccine to a young child, we were going to make them sexually promiscuous because they wouldn't get this virus. Nothing was further from the truth. So it took quite a while for this vaccine to take on. And then also there were a few deaths in women, young women in this age that received the vaccine that after the fact were not felt to be related, but the time was such the vaccine did not get very far initially. But it is a vaccine, as you can see, it prevents HPV infection that causes cervical cancer, genital warts, and then the risk of cancer of the vagina, the penis, anus, and head and neck. So as you can see, it's a male and female vaccine. Did I say it was a vaccine that prevents cancer? Well, if you didn't get it from me, you might have gotten it from all those TV commercials. Mom, Dad, did you know? When they show these young teens who are now at risk because they didn't get the HPV. Very, very, very effective commercials. They're not on anymore. They probably ran their course, but it was truly an eye-opener to me how important it was for this vaccine to be prescribed. The trade name is Gardasil, and it treats the species of cancer that cause, the species of HPV that cause cancer. 90% of the cancers can be prevented with this vaccine. As I said, it's girls ages 9 and above, boys ages 11 and above, because boys can get genital warts and boys can ping pong the vaccine back and forth with women. For the women in the audience, through age 26, you are still eligible to get this vaccine if you didn't get it when it first came out or you have passed that age bracket. And men through age 26 as well. But now, most recently, the new recommendation is if you're a woman between 26 and 45, you may actually need this vaccine. It's a conversation you have with your physician. The less exposure that you have had to sexual contact, the better chance this vaccine is going to help you. So if you've had limited sexual contact, limited partners, you may benefit because this vaccine may prevent you from cancer if you had not been exposed to those 9 different species of virus. So as an internist, I do not give this vaccine in my office, but I strongly encourage women to discuss with their gynecologist because those women need that kind of care. It's probably most obviously given in the pediatric office and in the gynecology office. Some family doctors may feel comfortable doing that. But it's something you need to explore if you've not had it. Okay. The next vaccine, I'm kind of focusing now on the older population. Those of us had chickenpox have the virus living in us. It lives in our nerve roots. Something triggers the reactivation and suddenly you have a blistering rash, other symptoms, you feel awful because you actually have an active virus going on in your system. It can be seen mostly around the trunk, around the lower abdomen, it's circular, or it can be in the face. And that's where it involves your vision and other organs. So this is not a benign condition. We're getting more and more cases of herpes zoster because as we were adults, we would be exposed to children who had who had chickenpox. But that number of kids with chickenpox is decreasing. So our bodies aren't seeing chickenpox anymore, even as the adults being exposed to a child with it. So we're really losing our immunity. And then add on, if you're under stress, you're on steroids, chemotherapy, you have other problems with your immune system. And again, stress alone can do it. So how many of us can say that we were stress-free in the last year? So what the goal is to prevent the shingles coming out as an actual infection. The trade name is Shingrix. It's 2 doses, 2 months apart. Has to be 2 months apart. When you get your first dose, you schedule your second. If it's less than 2 months, you're not doing yourself a favor. The chances of developing shingles and the complication, which is post-herpetic neuralgia, which is that horrible pain that goes along with shingles that does not go away, is significantly reduced. The vaccine is 90% effective in preventing you from having another outbreak of shingles, even if you had one before. So if you've had shingles, you need the vaccine. If you had the first shingles vaccine called Zoster, you need the vaccine. It's one and done. You get this vaccine once. It's indicated for adults over the age of 50. Once means 2 doses, and it really decreases the risk of you having illness. When you think of shingles, you think, oh, it's just a rash and I have some pain. No, it's not. When people have shingles, there's an increased incidence of having stroke and heart attack after you had the shingles episode. A 40% increased risk of a heart attack or a stroke from the rash. So it's not a rash, it's a significant condition. The vaccine is out there. The old vaccine is gone. The new vaccine is here. And even if you have immunized compromised, if you have chronic illnesses, speak to your physician. More times than not, they will recommend that you have this vaccine. So the last one I want to speak about is the flu. And I left this for last because essentially everyone needs to have a flu vaccine, starting at the age of 6 months. So whether you are 2, 20, 22, 92, you need the adult vaccine called influenza virus vaccine. There are many types. There's types because you're older, because you might be over the age of 65, and we want to give you a stronger vaccine because that's important, that your immune system isn't working very well. And we want to make sure that we give you an extra dose of the vaccine to be able to overcome your immune system's weakness. Now, for those of you who are afraid of needles, and there are some of us who are like that, there is a nasal spray. So instead of getting the vaccine and a needle in your arm, you snort this fluid up your nose, and that is a way of getting the nasal spray. Now, you have to be okay with that. There's no other way to do it, and it's only indicated for a certain age group. That age group ends at the age of 49. So if you're afraid of needles and you're over 50, you're going to have a vaccine. Now, you might say, I had the flu vaccine last year. Why do I need it this year? Because every year the vaccine is different. So that virus is very smart. It mutates, it changes itself so that the vaccine from last year is not going to be effective for the virus this year. So, and every year you need to have this vaccine. And when do you get it? Please, please, please do not go to the pharmacy in August when they start saying, I've got the flu vaccine. It is way too early. Most of us feel that the month of October is the earliest that we would give of a flu vaccine. And if you have chronic conditions, you're a diabetic, you have COPD, you have chronic infections, then October would be the time to do it. If you're a little bit healthier, let everyone else get their vaccines in October. You can get yours in November or even December. Interestingly, the flu season lasts through March. So when I see people in February who haven't gotten their vaccine, I'm still giving it to them. It takes about 2 weeks for the vaccine to kick in, to generate the antibodies so that you are protected. But my feeling is there's been some years when we've had a flu season that lasted as long as April. So if I can give you the flu vaccine in January, February, I will do that because then you are protected. And, you know, when you're protected from the flu, think about the community. all of the people that you live with, that you're in contact with, that community is protected as well. So you're doing a solid for them. To give you an idea of how prevalent the flu is, I just put some numbers up. Now, these numbers of flu is much more than COVID, but every one of us needs to be part of the team that makes these numbers less. There were 38 million cases in the season of 2019 to 20. And interestingly, 15 million of those cases were in adults from the age of 18 to 49. It's the same group of people who don't think they need to get the COVID vaccine anytime soon and who don't follow the social distancing and the masking and what have you because they feel that they won't get sick. This is the highest number of young adults to ever get the flu. 15 million, almost a half. So it's not just a disease of the elderly, it is a disease of your college students, your high school students. There are 18 million healthcare visits, meaning 18 million people went to the doctor, the urgent care center, the ER for care. 400,000 people were hospitalized and 22,000 people died. Now, you might say, okay, those numbers are a lot less than what we're dealing with COVID right now, but they are unnecessary deaths. We know about the flu. We know everything there is to know about the flu. We know the vaccine works. 22,000 people died because they got the flu. Would every single one of them been saved if they had gotten the vaccine? No. But you wouldn't have had 15 million young adults who now have missed school and work and social events. And you're not down for a couple of days, you're down for quite a while. And if you don't feel well and you're not on your social media for a few days as a young adult, boy, you're truly, truly lost. So I wanted to end by saying thank you. Our office is Rowan Medicine. We're here on the campus of Stratford. We have availability for vaccines, vaccine education. My feeling is most vaccines are paid for through your insurance company at the pharmacy. So some vaccines you will need a prescription, some you will not. But if nothing else, I hope that I've been able to raise your awareness so that the next visit with your primary care provider, you discuss vaccines and say, hey, what do I need? So thank you.
Thank you, Dr. Kaiser-Smith. Coming up next will be Dr. Lambert, who's here with us today. And Dr. Lambert is the Associate Professor of Family Medicine at the Rowan School of Osteopathic Medicine and an Assistant Dean for Student Affairs. Dr. Lambert's interests include all concepts of family medicine, but also sports medicine, and she holds a certification in sports medicine. So very happy to introduce Kathy to you today.
Thank you. Thank you so much, Linda. I'm going to share my screen here. Okay. So let me also say that in addition to, that information about my background, I've also been a team physician, school physician for local high schools for well over 25 years. So I've had a lot of fun taking care of athletes at schools and in my office. And naturally, I was asked to sort of share with you some tips for just handling common sports injuries. So tip number one is terminology. A lot of times people don't understand the terminology in musculoskeletal and common sports injuries. First, ligament injuries. Now, ligaments run from bone to bone, typically across a joint, and they provide stability to that joint so that you don't feel like your joint's wobbly, that it kind of, when you're moving your joints, it kind of holds the bones together by all the joints across going bone to bone. So when you tear those ligaments, overstretch, get some micro overuse injuries, those are called a sprain, S-P-R-A-I-N. So when you injure your ankle ligaments, it's an ankle sprain. Knee ligaments, knee sprain. Wrist, thumb, wrist sprains. Occasionally, there are other ligaments that go from bone to bone that have a different type of injury called fasciitis. And probably the most common example of that is the plantar fasciitis, or the ligaments that run on the underside of the foot that can sometimes get injured from excessive running on soft surfaces, excessive training, and sometimes being very flat-footed or prolonged standing or walking. Now, muscles also connect at a bone, and they go from a bone to another bone, but they end in a tendon. So muscle tendons work as a functional unit, and muscles start at one bone, typically going across a joint, and the muscle tendon unit provide that movement or functionality to that joint, whether it's the little joints of your hands or your knees, your shoulders, your ankles. So muscle injuries, if you overstretch, tear, micro tearing, overuse, those are called muscle strains. So you don't strain a knee, you might strain a quad muscle or a hamstring or a biceps muscle. Occasionally, you might have direct injury or inflammation that will cause myositis, but most of the time we refer to them as muscle strains or quad injuries, muscle injuries, typically called strains. So you don't strain your ankle, you strain your quadriceps. And sometimes when you have a muscle tendon injury, they may be more injured at specifically the tendon, which is that connective tissue attachment of the muscle or the muscle group into the bone where across a joint. So if you have injury, tearing, micro injury from overuse, that might give you tendinitis. Examples are patellar tendinitis, Achilles tendinitis, which goes across the ankle. Patellar tendinitis goes across the knee. Sometimes biceps tendinitis or wrist tendinitis, we see people who overuse their wrists. So just starting out as your first tip is keep in mind the types of injuries and the terminology. Now, whether you're a competitive athlete, a weekend warrior, or a very active person in between, injuries do happen. And when injuries happen, you want to know, what do I do about it? How do I treat it? So I thought I would share as my next tip for you is basic injury rehab. So I know that many people have used this concept of RICE, or rest ice compression, for treating athletes for decades. You know, I asked my 20-year-old daughter the other day, so have you ever heard of, using the RICE approach for treating injuries? And she said to me, no, Mom, I just know about using RICE for treating my injured cell phone. So I guess maybe the RICE approach isn't as well known as we might think. But in sports medicine, in non-operative orthopedics, we've expanded the RICE approach to the PRICES approach, adding the concept of protection and support to the fundamental concepts of RICE. And let's talk a little bit about each of these concepts and how they might be applied. So the concept of protection, or P, that concept is when you have an acute injury to your body. Sometimes it applies to chronic injuries, but when you have an acute injury, how do you protect that affected body part from further injury in the acute phase? So you've sprained your ankle, you have a bad ankle sprain, and it hurts if you walk, so that's your body telling you not to do it. How do you protect that body area? So if you put weight and use that body area too much, you will stretch those ligaments, overstretch those muscles, and you could continue to cause worsening injury in those first couple of days when you're rehabbing from that injury. So protection is about what can I do, or what does your doctor recommend to protect you from further injury in that acute phase. Common example is the use of crutches for lower extremity injuries. Sometimes for a foot or big toe injury, you may not need crutches, but to really allow that area to be protected, you might use a hard bottom shoe called a Darko shoe. That prevents bending of your toes when you put pressure on it. For upper extremity injuries like a dislocated shoulder or another type of injury of the shoulder girdle, we might use slings. Sometimes we'll use splints across a joint to maximally rest that tendon or those ligaments, just to prevent a person from everyday activities worsening and causing further injury. And of course, if you have a broken bone, you're going to be casted, because casting, or now what we use are things like cast boots, which is sort of a removable cast. Those kinds of casts are fixed types of immobilization. A leg knee immobilizer is another example of a fixed immobilization. For those times, whether it's a couple days for a knee immobilizer or weeks for a cast, it allows that body part to heal together. And then in the case of a bone injury or fracture, that just takes a much longer time to heal properly. And that's why we end up needing to wear casts and protect that broken bone for weeks. So always think protection from re-injury acutely when you have an injury. So then your next concept is going to be, how do I rehab this injury? First thing is, think rest. Rest allows maximal healing. Use of crutches, casts, splints, slings, that really allows that maximal healing for a significant acute injury. And that's why we do that. And why is rest important? Because the body has this tremendous innate ability for healing, and allowing rest and preventing acute re-injury maximizes that healing. Now, for some injuries, generally sort of overuse injuries, an example might be shin splints or a stress fracture of the foot. That may be relative rest. So we may not put your foot into a cast or a cast boot. We may take you away from those activities that are causing this chronic microinjury. So that's an example of where, instead of absolute rest, we may still allow you to walk, still allow you to do activities such as walking, everyday activities, but remove you from your sport or your training, which were the offensive activities that caused the chronic overuse injury. So rest is an important R. Next, you want to be thinking, and this is all at the same time, ice. Ice decreases swelling and inflammation by vasoconstriction. So when you put cold on a body area, you have vasoconstriction, and then any leaking of fluid, plasma, intracellular fluid from the tearing of the tissues, from the capillaries, that will be minimized, and it'll help to decrease the swelling. And I'll talk in a minute why decreasing the swelling is important. Ice can also be useful because it has a direct numbing effect on pain, directly on the pain fibers. For some people to help manage their pain, that can be a very, very useful strategy as well. I will give you Dr. Lambert's rule of fours for using ice, because typically I find that ice is underutilized. So when you have an acute injury, you want to apply ice for about 20-30 minutes on. Usually you'll put like a thin cloth or a thin terry towel on your skin, but you apply ice for 30 minutes on, 30 minutes off for 4 hours. Then after the first 4 hours, utilize the ice for 20-30 minutes in a row at a time for the next 40 hours. That's somewhere between 36 and 48 hours for the next day and a half to 2 days. Then after that point, if you're still having some ongoing pain and or swelling, use ice for 30 minutes 4 times a day. So that's my little tip on the rule of force for using ice. Most people underutilize ice, and ice can still be beneficial if you're having some ongoing pain and ongoing swelling. The next letter in crisis is C, and C stands for compression. Compression is helpful to decrease the localized swelling by applying back pressure to the affected body area, and the back pressure so that the fluid that's leaked out in your tissues will then be sort of squeezed back into the veins and the lymphatic drainage systems. So this is helpful by to enhance the drainage of these two systems and improve and augment the resolution of any swelling that has occurred as a result of the acute injury and tearing of those tissues. So this helps to reduce the swelling. And the next letter, or E, helps to decrease swelling by just promoting gravitational drainage. This is why you talk about elevating your legs or holding your arm up to relieve the swelling. Ice, compression, and elevation together work to maximally resolve the swelling. And by resolving the swelling in the torn tissues and the affected body areas, it allows some of those connective tissue fibers to sort of realign and to promote healing and to get you back in the game or back in the activity faster. Often you'll see that the level of ongoing swelling can be a limiting factor to getting an athlete or anyone back to the activity they want to do. In professional sports and often in college activities, you'll see some of these modalities combined. We'll have ice, cold water, iced water, compression boots. So that's a compression and cold combined to squeeze out and keep that body area chilled to, again, maximally resolve the swelling, which helps to augment the healing process. So then that brings us to our next letter, which is support. And this is an area that many people forget to include or think about when they're coming back from an injury of some sort. The concept of support, which sometimes is referred to as a functional type of protection, is what can I do as a patient, as a physician, as a trainer to support an injured area upon return to activity. Why is that important? Well, so many times I've seen athletes who had an ankle sprain and 2 weeks later they come back with another ankle sprain because they did their rehab, they were feeling pain-free, but it wasn't 100%. That'll take more time. And they went back to their sports or their activity, and then they were at a stressful twisting, turning kind of activity, and they re-stretched and re-tore those ligaments. So wearing a brace or doing ankle taping can be very beneficial in helping to support that injured body part. So always think, what can I do to support that injured body part to prevent re-injury in the convalescent and ongoing phase? And this is examples I want to show you, but we think of these as braces, supports, taping, other types of activities, and they'll vary depend on the body part that was injured. So let me show you a couple of examples here. Here I just pulled out of my files, I pulled out some examples of common braces, supports that we use. Now, this one here, the first one in the upper right, is an example of an orthotic. So it's a rigid but cushion top insert for a shoe. If someone is very flat-footed, that can cause chronic stretching on the plantar fascia and cause microinjury, tearing, pain when you get up, pain when you walk around. So thinking using a support, if you are very flat-footed, can be an ongoing way to prevent chronic re-injury. Another very useful thing, especially if the pain is back in the back of the heel, what they call the medial posterior arch, are using heel cups. Now, the bottom left here shows the yellow ones I don't like as much, but that's why I show them, to show people this is what I don't like, versus the bottom ones, which are nice silicone wedge heel cups that are useful in providing both shock absorbing and taking the stress off of those injuries and the injured plantar fascia. Sometimes we will use these types of heel cups on the bottom, the darker brown ones, for Achilles tendinitis, because by raising the Achilles up and providing more support, this decreases the stress and the micro injury to that tendon as it's healing up from an Achilles tendinitis injury. In the middle here, I have two examples of ankle braces that I like a lot. The top one is a lace-up ankle brace. A McDavid or Sweeto model is an example. You'll see the toes and the heels are cut out. You have to wear a sock with those. These are great because they provide external support across the ankle joint. So when you're healing from an ankle sprain, this provides that extra support to that ankle as you return to activity pain-free, but supporting those ligaments that may still be a little tenuous. So this is a great thing to think about using, and a lot of our athletes use these. The bottom ankle, which is the active ankle, that has more rigid support across the ankle, so that these areas here are very rigid, but it has a hinge joint, so it allows more functional use for the athlete who wants to use a slightly more rigid brace, given the activity that they're doing, like football, or other contact sport where they want to have more protection. The two braces here next to the right of the ankle braces are knee braces. Now, the difference with the top one is that has a hinge. So if you had a knee sprain and the ligaments go across the knee, that hinge provides functionality, but really good support for those ligaments to prevent them from being bent one way or the other and re-injured. The bottom one is a tendinitis brace, also and also used for mostly for patellofemoral syndrome, which is where the kneecap, you see the kneecap here has extra foam padding to help keep it tracking in the midline. A common sports injury of the knee is patellofemoral syndrome, where the kneecap rubs on the thigh bone. And using a brace like this after you've rehabbed and now they're pain-free helps them to stay pain-free and helps the kneecap to track better and enables your athletes to get better and continue their activity with that support and preventing micro injury. And then just a common brace I wanted to include on the far left there is the thumb spica brace. We use this when the thumb has been injured, skier's thumb, sometimes gamekeeper's thumb. If you fall funny and you injured the thumb, that can be very useful for thumb ligament injuries. It's also very useful for a common tendinitis known as de Quervain's tendinitis, which is tendinitis of the snuff box on your wrist. This allows you to have functionality of the rest of your hand, but allows that injured ligament or tendon to get maximal rest while you're doing rehab. And then if you still aren't 100%, or say you work at a store or using a computer and you have a lot of injury with your work activities, this splint might be useful to help you get back to those activities and not overuse and support that injured body area from re-injury in the convalescent phase. So that can actually be used for both protection and support. So these are just some common examples of braces that people can use, doctors can recommend, that can be helpful. Once you've rehabbed your injury and now you're going back to your activities, nothing replaces the concept of long-term rehab. Fundamentally, if you've had tendinitis, if you've had chronic knee injuries, like you've had a chronic quadriceps injury, or your hamstrings are really tight, or you had a hamstring pull, and now you've rehabbed that and you're better, but nothing can replace the long-term stretch and strengthening to keep you in the game and to keep you feeling well and healthy. There's lots of things we'll do. We'll recommend athletes to go into physical therapy, work with their trainers, in our doctor's offices. We will recommend different types of programs for stretch and strengthening. Women typically have tight Achilles, so look to stretch out your Achilles by doing, heel cord stretches. Women typically have weak rotator cuff, so wanting to strengthen your shoulder girdle and your rotator cuff by doing hand weights or controlled weights in multiple positions to strengthen those muscles is in the long term what helps you do well and stay well. I put in here, if you're interested in more specific examples of injuries and rehab strategies, a great resource that we use in our office is called the Sports Medicine Patient Advisor book by Dr. Pierre Rosier. He's a family medicine physician, but he's done a lot of teamwork. It's now in its 3rd edition. You can buy it online, but it has things organized by injury, and it has some great photos of the types of rehab exercises a person can use both short-term and long-term to stretch and strengthen those affected body parts to help keep them well, stay well, and enable them to play their activities and do the things that they want to do and stay in the game. So those are my tips for you today. I included some lovely calming photos. They say you can never do wrong with some lovely photos. These are from Longwood Gardens in the last week. But if you have any specific questions, or I'm sure if you have any specific questions for Dr. Kaiser Smith, we are happy to take them now. Thanks so much.
Great. Thanks, Dr. Lambert. That was wonderful. I don't know if there's any questions. If anybody wants to add to the chat, we're more than happy to field questions. And if not, I can come up with some questions that were developed before this program. Give me a second. Okay. So for Dr. Lambert, what do you find is the biggest mistake people make with rehabbing an injury?
So the biggest mistake I find are twofold. One is not protecting from acute re-injury, so walking on an injured foot, ankle, knee too quickly. 2 is not putting the effort into rehab. And 3, being really great and raring to go, but not thinking about what they can do to support. So that's why I like to include that whole crisis approach, that it's really great when you rehabbed an injury, but then if you go back and re-sprain that ankle, it's so frustrating. So always think to yourself, what can I do? The other thing is sometimes people will make training errors. They will do too much too fast, and that causes the injury, or they will have improper footwear, and that causes the injury. Or they're exercising on, let's say, running on too soft a surface like the beach. So look at your training protocol if you get this overuse injury and where there might be fine tuning that you can do to help you with that.
Thank you. And next is for Dr. Kaiser Smith. This is a question. I'm just getting over shingles. Do I need the vaccine? And if so, when should I get it?
That's a very good question. Thank you. Yes, if you've had shingles, that virus is still living in your body and you can get shingles again. But the good news is that your body has developed antibodies against that herpes vaccine virus. So it's said that you can probably wait about a month before you go get the vaccine. You'll have that increased antibody level in your system that will drop again at some point. So I usually say wait about a month and then get going. You want to make sure that your rash is healed, that any blisters that you had, that's all crusted over, and you're feeling well. You may get a little bit achy from that vaccine, so you don't want to get a vaccine that makes you feel worse before you feel better. But it's very, very, very necessary.
Thank you. Dr. Lambert, how do I know when to see a doctor for an injury?
That's a great question. Thanks, Dr. Brecker. A common question I hear. I always tell people to listen to your body. If you're having pain that's lasting more than 24 to 48 hours, you probably need to go get that checked out. And if it's getting worse, that's another reason to go get it checked out. If you've injured a leg body part, if you can't walk 4 steps without pain, you need to go get that checked out. So listen to your body, listen to the pain. If you're having severe pain, persisting pain, you're unable to do just elemental functions, go and get it checked out to be sure.
Thank you. Again, for Dr. Kaiser Smith, this is an adult who said, I've never had the HPV vaccine. Is it too late? And what should I do?
Okay, well, as I stated, the vaccine is usually started at the age of 9, and depending upon when it's the series of vaccines are usually done within a year of starting. So if you never received the vaccine because you were, beyond that age or didn't know about it, and if you're under 26 years old, you put that on your to-do list to reach out to your primary care physician or your gynecologist to say, I would like to come in and discuss the HPV vaccine. You'll have a conversation with your clinician about the risk and benefit, whether or not how your sexual activity. You will have to talk about your sexual activity to get an idea of whether it's worth giving you the vaccine. And if you're over the age of 26 and you're between 26 and 45, again, that same conversation. My gut feeling is if you're under 26 years old and you've never had the virus to your knowledge and you've never had the vaccine, you should get it. Between 26 and 45, it's an informed decision with you and your primary care provider or your gynecologist.
Great, thanks. Dr. Lambert, after sports injury, is there any benefit or even risk for taking over-the-counter medication like acetaminophen, ibuprofen, naproxen, or both?
That's a great question as well. So when an individual has an acute injury, that's typically associated with pain. So some of those medications are very helpful in managing the pain so someone can sleep, so someone can at least be minimally functional. Tylenol or acetaminophen is very useful in that it doesn't affect inflammation, cytokines, and chemicals in your body. And it will be helpful for pain. You just have to make sure for any of those medicines not to overuse them. For some people, the ibuprofens, the naproxens that are over the counter can work better for them, and they do help with the swelling. And as I said, we want to help with the swelling. And those are okay to use for a limited amount of time, for a couple of days. We don't usually recommend that long term. One, for the potential impact on your stomach, your GI tract, as well as we think it loses benefit long-term for acute injuries. There is a school of thought in sports medicine that when your body has an injury and that microtearing happens or macrotearing, it releases a cascade of chemicals, cytokines, interleukins, things like that, that are part of the pain process, part of the swelling process, but also are part of the healing process. So for that reason, a lot of people in sports medicine like to minimize the use of those medications to have an adverse effect on those chemicals. But when it comes down to pain and functionality, sometimes you need to use them and it's okay.
What's your feeling on the topical anti-inflammatories, Voltaren gel?
That's a really great compound now. That's out now. That also has an anti-inflammatory chemical, and that's probably less absorbed into the systemic system, not as much. Clearly, the GI impact of using a topical anti-inflammatory would be minimized, if anything. So I think that's a great choice. But again, whether that impacts the local cytokine activity in the healing process, that's all theory. So I can't tell you that it's doing harm, but I think it may likely in the short run do more benefit than harm.
Can I interject here a second? I got a question emailed in.
Sure, perfect.
This is actually for Dr. Kaiser Smith. With the COVID vaccine, they're saying that taking over-the-counter medications can actually affect the efficacy. Is this true of all vaccines?
Not to my knowledge. Your ability, the vaccines that we have are tried and true. If you're chronically on these medications, I would not be stopping them. If you are looking to take a medication because your arm hurts because of the vaccine, I would, lean more towards acetaminophen as opposed to the anti-inflammatories, because it'll do the same thing. We're just talking about pain and inflammation. But don't stop your chronic medications because of this vaccine, of any vaccine. Other than COVID, again, I don't want to speak for COVID because it's a totally separate condition. You have to follow what's out there as the guidance for that.
If I could just add, just as a rheumatologist and using a lot of immunosuppressive medication, there are specific data theories that we follow regarding immunosuppression and vaccines. People on methotrexate that get the flu vaccine, they should hold methotrexate for 2 weeks after the flu vaccine, and we feel the vaccine will work better. There are several other immunosuppressive meds that we may hold depending on how stable the patient is, just to help the vaccine to work, because some of our medications interfere with both T cell and B cell function, which are part of the immune system that allows you to react to the vaccine. So I would say, just to be safe, if you're on any immunosuppressive medication, even including steroids, that you should definitely speak to your provider who prescribes the medications, and they can be a better resource for that. Let's see. Trying to think if I have anything more here to keep us going. Dr. Lambert, what can I do to prevent sports injuries from happening?
So prevention is always a huge plus for whether it's COVID or disease or injuries. I think the most important take-home message is, one, you have to train appropriately. Don't overtrain, don't train too much too fast. Make sure you have proper fitting equipment, whether you're a runner and it's shoes and they're not worn out, has proper support, whether you're an athlete, whether you're playing tennis and your grip is kind of losing or it's too small, too big for you. So proper equipment, proper training. And at the end of the day, if you can do strengthening of the areas that you want to especially use for your sport. So if you're a runner, lower body, especially if you're playing tennis, it's lower and upper body. Make sure you do strengthening. So many people lose the element of actually dumbbells, other exercise, the calisthenics, or going to the gym and using controlled weight machines to build muscle mass. And that's so important for younger athletes and so important for older athletes, as we often lose muscle mass. And for women, using weight bearing or weight activities will build your bone. And I know that's really important to Dr. Brecker and the work that she does to build her bone. So not overtraining, proper equipment, and strengthening of the targeted body areas in the activity you want to do before you engage in that activity.
Great, thanks. I think we're getting close to the end. I want to wrap it up a little bit. I want to really thank our panelists for some wonderful presentations. I especially want to thank Jane Elliott, who has been coordinating this all behind the scenes and has supported us through this entire mission. I want to mention that we're doing this program. We're doing it every month through June on the second Wednesday at lunchtime. So again, 12 to 1. There will be many great topics coming up. If you have any topics that interest you, we have a wealth of great women providers, physicians, specialists that work with us. So we're happy to think about any topic that would pertain to women's health or family health, and we'd be happy to work on that. But I thank everybody for attending, and we are open to any comments, criticism, ideas, or anything you might have. So that's about it. If anybody else has any comments, we're good.
Thanks, everyone.
Thank you. Have a good day.